everyone. This is the 6th panel of the Congress. First of all, I want to thank the organizing committee for this Congress. Almost 2 years we had no face-to-face congresses, and we were used to online congresses. We are very happy to be with our friends here socially. My co-chair is Professor Tiraje, and she's from Istanbul. Our speakers are Dr. JIMENEZ-YUSTE and Robert KLAMROTH. Now we want to start with Dr. JIMENEZ-YUSTE. He will talk about non-replacement drugs. He is from La Paz University Hospital, Madrid, Spain. And he is working at Autonomous University, medicine at the Autonomous University of Madrid and head. And he is a member of Executive Committee of the Spanish Society of Thrombosis and Hemostasis and EHAD. His lines of research include the treatment of disorders of hereditary clotting, ITP, and acquired hemophilia. He has published more than 150 journal articles different on these topics. Now we are ready to listen to you.
Yeah, thank you so much for this kind of introduction. I want to thank you for your invitation to be here. As you mentioned, I apologize not be there with all of you. It was my fair intention, but here the situation when I have to decide it was not quite good. So at the end I have choose to do it online. So thanks again for inviting me to be the organizer and you in this International Congress of Hemophilia. So as you said, I will discuss during the next minutes about the non-replacement drug in the treatment of hemophilia. So from the initial treatment, this is probably the most famous hemophilia patient. It was the Tsarevich in Russia. And from this historical point of view till now, we have a great advance starting from the cryoprecipitate, then the factory concentrate. Later we have of course the pandemic with HIV, hepatitis C in our patient, and then arrived the factory concentrate inactivated, and then we were able to create a recombinant product. Now about the standard half-life that we are going to discuss later. But in the last year we have had a new mechanism of action, and the reasons why. In the last year, they have all this evolution in terms of different mechanisms of action, gene therapy, extended half-life, and this is one of the thoughts of Professor Manucci about that this thing that we have a very good anticipatory treatment. Why we are evolution in the future, and probably the reason is that we have still some limitation in our current factor replacement regime, and this is why. We are now in a moment of transformative treatment that we try to address or to fulfill all these unmet needs in the treatment of our patient. So now when we think about moving from the classical replacement therapy to a non-replacement therapy, we expect it when we change or when we will plan in the future to change our patient, we will expect it a benefit for our patient, and mainly this will impact on the breathing frequency, on the joint status, on the physical activity, in the quality of life, in the treatment burden. So this is probably the unmet needs that we still have, and this is why we are working on that. So this is why now in the hemophilia field we have new drug, new elements. And I want to briefly, in one slide, try to give you a picture of how the situation nowadays about the current and the future option. Now we have the standard half-life, classical ones with plasmatic or recombinant. We have the standard half-life you are going to discuss later with the fission, FC, PEG, albumin, and in the future, the factor and nanobodies. Also we have 9 new category called high sustain, that's included a new product that is joined to babulinum factor, factor A and extend. And I will discuss about the non-replacement therapy with emicizumab. MyMate is also a similar drug, Fiduciary, continutumab, serpin, and I will discuss later. And also we have in the future, or very close, gene therapy for our patients. So I will focus mainly on my presentation on non-replacement therapy, and I will start with emicizumab. Emicizumab, it was a disruptive therapy that arrived. The mechanism of action is very, very interesting. Is there in hematology we have only two bispecific antibodies. One is blinatumomab for acute leukemia, and now is emicizumab for hemophilia. He's able to join activated factor 9 to factor 10, here is emicizumab, and replace the action of activated factor 8 by binding to both factors. So he will restore the coagulation cascade in the absence of this drug. And when we published in Blood the phase 1 trial, there was an editorial from Professor Macris that you have also as a speaker, I think yesterday or 2 days ago, I can't remember, I see the program. He said that there was a disruptive technology. And disruptive means that it's something that changed completely, the same change that we have observed with the email compared with the postal mail or the new smartphone compared to the classical phone. And this is what we observed when the results of the HEMOFILIA. The HEMOFILIA was the trial in adults with inhibitors. And we observed that our patients that were in prophylaxis with emicizumab compared to patients without prophylaxis, they have a reduction around 87%. And also we have around 60% with zero bleed. It was the first time in the inhibitor field that we observed that, and for us was an important change. But also in this trial, we observed that when we compare our patient that was prior with prophylaxis with patient agents, and then we move to emicizumab, we observed a reduction of 80%. It means that when we compare each patient with themselves, we observed that they was able to reduce the ABR. So there was a very interesting data, and this is something that in the field of inhibitor we never observed. For us was a radical treatment in our patient, and the same results were observed in children. This is the HEMOFILIA. This is the trial that was designed quite similar to the HEMOFILIA. It was in adults, in children, and this is the 15 children that have this interpersonal comparison. In blue, they are the ABR, the bleedings before starting the trial, and in yellow is during the trial. So you can see the huge amount of number decrease. There are some patients that have zero. It's something that we expected because children have less arthropathy, has less synovitis, so the drug could work better. So this is the amazing result that we observed in inhibitor. But of course, the next step was moving and try to observe what happened in patient without inhibitor, in hemophilia A without inhibitor. And this is the result of the HEMOFILIA. And the HEMOFILIA here in the right, you can see the patient on demand have a reduction when we move to emicizumab once per week or every 2 weeks, around 90%. This is something that we expected, of course, because if we have the previous result of patient with inhibitor, why not observe the reduction in patient with inhibitor, without inhibitor, sorry. But I think that the most important result is that patient that was prior on prophylaxis with factor 8, when we moved to emicizumab 1 dose every week, we have a reduction of 68%. So it was demonstrated that there was some kind there was still place or room to improve the prophylaxis in our patient. This is the publication of the HEMOFILIA, and also there was a trial that demonstrated that it could be used every 4 weeks. It was the HEMOFILIDE that demonstrated that in patients with and without inhibitor. Very recently, having published the pool data of all the trials, and in a long follow-up, and when we observed that this reduction in ABR in the different trials, having 1 adult with inhibitor, having 2 children with inhibitor, having 3 patients without inhibitor, and having 4 patients every 4 weeks, we observed that the number of ABR decreased along the time. What is the reason? The reason is mainly that initially the patient improved the health of the joints and probably decreased synovitis, and this observed this reduction. And this is true because also it was maintained in terms of the proportion of patients who maintain a joint and spontaneous bleed over the time. And something that I think also very interesting is this indirect or surrogate marker of possible joint protection, because there was around 90% of target joints resolved. So patients who enter in the trial resolve the target joint. So it's probably a surrogate marker of probably health rotation or something that could help us to maintain the joint status for our patient. But of course, there was some kind of adverse events, because there is a drug that activated coagulation, and I'm going to show you mainly the most important adverse event appears in the HEMOFILIDE adult with inhibitor. There were some cases of thrombosis and some cases of thrombotic microangiopathy, and this is there was a disease completely different what we have observed in the classical TTP with low levels of ADAM13. Here the mechanism is completely different. The levels of ADAM13 are normal. So this is something that initially we were very concerned about that. But later, when the data were analyzed, we observed that it was related to patients who received emicizumab in associations with APCC. Because in patients who receive a 7A to treat the bleeding episode, there were no cases of thrombotic of the TMA. And in the patient who received APCC, only in this group who received more than 1 day and more than 100 units per kilogram per day. So this is the group of patients who have really the thrombosis. So what happened? That the company during the trial have some kind of recommendation in order to mitigate. There was that, and the recommendation that is started to treat our patient with recombinant 7A and use only APCC in case of a failure to treat a bleeding episode with 7A, and try to reduce the dose almost 50%. And this is something similar that we have observed in the STACY trial. STACY trial was a trial that had been presented at the final result now in July in the STH. It's the long-term observation of patients with inhibitor and emicizumab, and it reflects the similar result in terms of safety with this drug. So I'm going to move to discuss more drug. This is a simplistic way to see the coagulation cascade. Of course, I don't want to discuss about recombinant of gene therapy. And I'm going to discuss mainly about this non-substitutive therapy. We have discussed about emicizumab, but I want to discuss with you then in the next minute about anti-TFPA antibodies and Fiduciary. In this view of the cascade, this is a new vision of the coagulation. This is a normal situation where there is a balance between clotting protein and anticoagulants, and the situation in most of us is that there is a balance between bleeding tendency and thrombotic tendency. But in case that happens in our patient with hemophilia, there is a decrease of protein of procoagulants and excess of anticoagulants. We have bleeding. So usually what we do is to add more red balls in this site. This is the substitutive treatment. But the new view is try to decrease anticoagulant, try to give again to equilibrium this balance and try to stop the bleeding. And this is why new drugs that act against anticoagulants are being proven or testing in clinical trial. The first is anti-TFPI. You know, TFPI is the inhibitor of the pathway tisular factor, and what has been designed is this two types of anti-FPI. One is that is only is block the domain K2. This is the concizumab and the Pfizer drug marstacimab I'm going to discuss later. And there was another drug designed by Bayer that add K1 and K2. The development of this drug was stopped because they observed an increase on thrombotic tendency and observed thrombotic in some patients. And now the drug that we are using is against the K2. And what happened is that blocking the TFPI with a monoclonal antibody, with the stop of the coagulation that is created by TFPI didn't happen. So at the end, the patient, we can control the bleeding. And this is how it works concizumab. Concizumab is the now on phase 3. This is the early results in patients with inhibitors, Hemophilia A, Hemophilia B. In this July, 2 months ago, they presented in the ISTH this tendency, the follow-up in the long-term effect of the phase 2 trial, and now the phase 3 trial is ongoing. So the difference, again, when we compare to emicizumab, is that concizumab could work also in hemophilia B, because here is not the mechanism of action is blocking TFPI. So this is the result in hemophilia A for all bleedings, for spontaneous bleeding or joint bleedings in hemophilia A with inhibitor, and hemophilia B with inhibitor. So there is a decrease in the ABR. So this is the point to move on to the phase 3. Of course, also with this drug, they observed in some point some thrombotic cases. So at the end, the trial was stopped in the phase 2 around 1 year ago. And then they observed that probably we need to decrease the associated treatment to the drug, and also the doses were changed. And now the phase 3 has been restarted, and now we are waiting for the result of the phase 3. And simultaneously, there's another anti-TFPA of investigations, marstacimab. Marstacimab is a similar drug, but the other drug was is from Novo Nordisk. This is for Pfizer, and it's a monoclonal antibody, as I mentioned before, that binds to the K2 domain of the TFPI. And there are some preliminary experience efficacy in non-clinical models, and also in the phase 2 trial. And all this data supported the progression to the phase 3. And now at that moment, also marstacimab are in the phase 3 trial. Finally, the last drug I want to discuss with you is the Fiduciary. Fiduciary is another mechanism of action, very interesting. It's RNA interference. This is a method that we have in all the in plants, in animals, in different species, and it works that trying to silence the production of the end of DNA. So if we design a specific interference RNA that are able to decrease the production of antithrombin. As you know, the thrombin is one key molecule in the anticoagulation or in the cascade. So we are able to decrease the antithrombin levels to around 20%. We are able to restore the hemostasis in patients, not only with hemophilia A, also in hemophilia B and another condition. So this is the trial that are ongoing. Again, in this molecule, they also observe some kind of thrombosis when they are associated with treatment to stop bleeding during the trial. And again, there was some mitigation measure established in the trial, trying to avoid or to decrease the number of this kind of complication. And finally, there is an opportunity for another targets in hemophilia. You know, the different serpins that are in the plasma. I mentioned one of them, that is antithrombin, but I think that there are different mainly work in protein C. There are some initial trials that are trying to block protein C. They're able to restore the coagulation and to compensate or to equilibrate this situation I mentioned you before. Again, in this balance, trying to correct the procoagulant state of our patient. My last two slide is to not to show you the new advances, but to decide something that probably is quite important is that now we are facing new treatments. Not, I saw you in a slide that we have a standard new factor A concentrates, non-substitute therapy, gene therapy, and now I think that one of the most important situation we are going to face different treatment, and we have different patients. So we need to find or to decide what is the correct treatment for the patient. So probably all these new drugs could be able to encourage to move patients from on-demand to prophylaxis. Probably we were able to reduce infusion and the need of renal central venous catheters in our children, improve the adherence, and probably enable to have a more active style life in our patient. So who benefit most? I don't know, but because we have to discuss, and probably patient with poor adherence, patients who have a severe bleeding phenotype, and also high levels of physical activity. So there are different factors in that could affect the decision. And my last slide is on that there are some proposal. This is a communication in the last ISTH for different opinion from different groups that probably based on the bleeding phenotype, based on the joint status, based on the treatment adherence, based on the venous access and the lifestyle, probably the combination of different conditions could help us in the future to choose the optimal treatment for our patient. So thank you again for your attention. Thank you again for your invitation, and I open to the discussion after the presentation of my colleague Robert Klamroth.
Dr. JIMENEZ-YUSTE, I want to thank you for your excellent presentation. We will take the questions and the contributions at the end of the session. So you have to wait a little bit. Now it's time for our second speaker. Yes, Dr. CELKAN.
Good afternoon, everybody. It is our pleasure to be here. We will thank the organizer bringing us, all of us here face to face, and also hybrid congress. And our second speaker is Robert KLAMROTH. He is the head of Department of Internal Medicine, Angiology and Hematology, and he is the director of Hemophilia Treatment Center in Berlin. He is expert in hemophilia and thrombosis. Also, he is having more than 1,000 scientific papers, and also participating in more than 30 phase 1 and 4 clinical trials and investigating. And Dr. KLAMROTH is the Vice President of EHAT, and also he is the Vice President of the German Society of Thrombosis and Hemostasis. Yes, Mr. KLAMROTH, it is your turn.
Dear ladies and gentlemen, dear colleagues, I'm glad to give this presentation about new therapies in hemophilia, next generation extended half-life factors. I'm really sorry that I'm not able to join you in person in Cyprus for this very nice International Hemophilia Congress of Turkey. I would like to thank Bülent Zulfikar and Kaan Kavakli for this kind invitation. And I hope at least yet we can discuss a little bit and you will get some insights from my personal experience about the next generation extended half-life factors and the treatment of hemophilia in Germany. So these are my disclosures concerning to this presentation. These are mainly companies who do studies where I participate and where there are advisory boards and I give presentations for them. First of all, I would start with the goals of our treatment. And I like very much the new WFH guidelines with aspirational goals to treat our patients as well as possible. And that the primary goal is that prophylaxis should enable people with hemophilia to lead healthy and active lives, including participation in the most physical and social activities similar to the non-hemophilic population. That was the goal of treatment already about 30 years in Germany, in this time formulated and postulated by Wolfgang Schramm. So that means for patients receiving factor VIII concentrates, they might benefit from an optimization of the existing prophylaxis with PK monitoring. And we all know that we refer to the trough level as for the effectiveness of prophylaxis. And maybe the factor VIII trough level, and that is really true for factor VIII, that 1% is not enough, and we need higher trough level for these patients who are still at risk of bleeding with a factor VIII level about 1%. And then the recommendations are to go for higher troughs like 3 to 5%. In Germany, we have, of course, local recommendations. The prophylaxis is a treatment of choice, and we all know the benefits for our patients if they are on regular prophylaxis. And in Germany, we're in a comfortable situation because our authorities, it's called the GBA, had a rapid report in 2015, and they recommended in this report prophylaxis in all patients with severe hemophilia, independent of age. And the goal is to prevent these patients from any bleeding, and especially joint bleeds, to prevent arthropathy. Of course, patients are different, and there's a variability in the bleeding pattern of patients and in the individual response to replacement therapy. So personalization of treatment can help and is, from my point of view, important. The new cross-sectional guidelines for therapy with blood components and plasma derivatives in Germany, we had an amended edition in 2020, recommends, like the WFH, a trough level for prophylaxis with factor VIII of 3 to 5%. The reason for this is that with the common prophylaxis we did now for a long period of time, converting patients with severe hemophilia to moderate hemophilia, there are still patients who are experiencing at least one bleed per year. And if we want to achieve 0 bleeds for our patients, then we need to improve prophylactic treatment. Here are 2 studies with a conventional prophylactic treatment and then more individualized prophylactic treatment, and still more than half of the patients experience bleeds. So there is, of course, room for improvement. That this prophylaxis, which we done before, has still not the ability to avoid joint disease in total, is shown here by a very nice study from my colleague Johannes Oldenburg. The Bonn Center adopted prophylaxis quite early in their patients, so they have now experienced over 30 years of prophylaxis. And you see here with the Patterson score and the Gilbert score that especially the ankles are prone to joint disease in patients with the common prophylaxis. So the long-term outcome in our patients with hemophilia is still not perfect with the existing prophylactic regimens. And the first step we did, and I think again you are familiar with this and do it in your country too, that we say, okay, we individualize the prophylactic treatment for our patients. There's none one size fits all regimen which is the same for all patients, but we adjusted, of course, to age and weight, with all pediatricians do for a long time with their patients. But we look for the patient goals. Are they physically active or mostly sitting at home in front of the television? What is the joint status of the patients, the bleeding frequency, the genetics, the adherence? Are they able to comply with our recommendations for regular intravenous injections? And of course, we take into account the PK response in order to advise our patients which activities are dangerous or not dangerous. So with the replacement of factor VIII or factor IX, we can reach levels where we normalize hemostasis. That is normally at peak levels after injection of the clotting factor. And we have a time where patients are in the mild range, in the moderate range, and even in the severe range. The severe range we try to avoid, and that is the trough level we measure, and then normally the next injection has to follow. And with the area under the curve, we have the overall exposure to factor VIII. So most studies in this field are done in hemophilia A and less in hemophilia B. So I will focus mainly on hemophilia A. There are very nice and interesting recommendations how to adjust factor levels to activity, and this was led by Alfonso Iorio and published in Hemophilia in 2017, which from my point of view is quite reasonable, that for surgery you need certain levels, for exercises you need certain levels, and with the replacement of the missing clotting factor, we can reach these levels, we can do any surgery, we can treat bleeds, and of course we can prevent bleeds. To help us to follow this pharmacokinetic idea of the treatment of hemophilia, I think very important is the WOPS Hemo system with a population pharmacokinetic service for hemophilia patients, where you can give individual data of your patient in and got on a population pharmacokinetic calculation, the half-life for the product, the individual product of the patients, and then you can adapt the prophylactic regimens. So there are different systems for PK in the market. I think the WOP system can be used for all existing factor concentrates. It's a big network, and we use it a lot for our patients to adapt prophylaxis to certain trough levels and to improve treatment. So what extended half-life products we have on the market? And I start with factor IX because the prolongation of half-life in factor IX products was much more successful than in factor VIII. We have two fusion proteins, factor IX FC and factor IX fused to albumin, and we have some pegylated product and 9GP. The prolongation of half-life is pretty similar with these different techniques, but the pharmacokinetic properties are quite different depending if the factor IX goes in the intravascular space or not. So the recovery for the pegylated product is much higher than for the factor IX FC product, which leaves the vascular bed. All in all these products are effective, and at least in Germany, nearly all patients with severe hemophilia B were switched to an extended half-life product. They are now on intervals of mainly once weekly, one intravenous injection to protect them against bleeding, which from my point of view is very convenient. In factor VIII, we have extended half-life products too on the market, but you see the prolongation from an average of about 10 to 12 hours for standard half-life factor VIII to up to 19 hours with the extended half-life product is not as convincing as in hemophilia B with factor IX. Of course, can we reach with this half-life prolongation already our goals to have a trough level of 3 to 5% or even higher to protect our patients? And I want to quote in this kind of PROPEL study, which was published in Blood in the last year. And maybe you are familiar with it already. So in the PROPEL study, we wanted to compare two factor VIII trough levels in patients with severe hemophilia A. These patients should be had before inclusion an ABR of at least 2 bleeds. And of course, inhibitor patients with a history of inhibitors were included. And all these patients got a PK assessment with 1 injection of 1 extended half-life factor VIII. And then there was a randomization to the usual guided factor VIII guided prophylaxis with a factor VIII trough level of 1 to 3%. And there was a higher group with a factor VIII trough level around 10%. And the idea was with a factor VIII trough level of 10%, we can have a higher number of patients with an ABR of 0. There was a 6 months run-in and treatment adjustment period, and afterwards a 6 months evaluation period of the primary endpoint. The primary endpoint was a number of patients with a total ABR of 0, or a spontaneous ABR of 0, or a joint bleed, a joint ABR of 0. And patients were randomized into the 2 treatment arms, irrespective of the individual characteristics. So PK played no role for randomization. And I only show you briefly results for the efficacy outcomes for the patients who complied with the protocol. So they reached throughout the study these trough levels. And you see here in red the lower dose group, and in gray the higher dose group, that the percentage of patients with a total ABR of 0, a spontaneous ABR of 0, and a spontaneous joint ABR of 0 is higher in the higher dose group. And if you look at the ABR, so the total ABR as a mean value with a factor VIII trough level of 1 to 3% was 2.8, and with a higher trough level was 1.2. So yes, the study showed that we can reach with an extended half-life factor VIII product on the market trough levels with 10%, and we can reduce bleeding further in these patients. What is the price? Of course, the price is you have to use a lot of factor concentrates, and you have inject in the higher dose group at least every other day. So the median injection frequency was 3.5 per week, but there were patients with a short half-life to have to inject nearly every day factor VIII. And of course, it's cumbersome, and it would be much more elegant to have a factor VIII product with a longer half-life to reach this trough levels, to avoid bleeding, but don't have these frequent injections. If we now look to the different approaches to hemophilia treatment, and I think Victor already told you about the non-factor replacement therapy, what I think is, what is the advantage of factor VIII or factor IX, that the factor level and the achieved hemostasis are pretty close together. So if I have a certain factor level, I can assume that I have a certain standard of hemostasis. I can do surgery in my patients, and with extended half-life products now, this is more reasonable for the patients in doing prophylaxis because they need less frequent intravenous injections. With a non-factor therapy, I can have the easy way of administration, that is sub-Q, but I have no close correlation with a factor level or with measurement in the laboratory to hemostasis. And there's always a lot of speculation. Might there be an equivalent factor VIII for the non-factor therapies? Especially for emicizumab, there are different numbers. I agree mostly with Peter Lenting that the factor VIII equivalent of emicizumab is around 9%. So our goal now is to convert patients with severe hemophilia to patients with mild hemophilia, which from my point of view is already a great advantage, but it's still away from a real cure of the disease. And that might be the possibility of gene therapy. I'm sure on this Congress we had some information about gene therapy, at least with the AAV-mediated gene therapy in patients with hemophilia A and B. normal ranges of the clotting factor are possible, but of course with a huge variability at the moment. But this can be measured. And so from my personal impression, the future will be maybe not with this first AAV-mediated gene therapy, but maybe with other gene therapy will be on the long run the treatment of choice. Until we reach this, of course, we have to do the best way to protect our patients against bleeding. And coming back to extended half-life factor 8 products on the market, which are now widely used in several countries, but even in Germany now, where we have the possibility by the healthcare system to prescribe extended half-life factor 8 products to all patients, the take-up is still not 100%. There are still about 30 to 40% on standard half-life factor 8, because the reception of treaters and patients is that the prolongation from 12 to 19 hours or of 1.5 is not a real deal. It's not enough, and we need some more. What is the reason that we were not successful so far with the prolongation of half-life of factor 8? And the reason is that in the circulation, 95% of factor 8 is bound to von Willebrand factor. And von Willebrand factor stabilizes and protects factor 8 from degradation, which is nice, but von Willebrand factor seems to be responsible for the limiting half-life extension, because the factor 8 von Willebrand interactions couples factor 8 to the von Willebrand factor clearance pathway. And so the circulating half-life of a Willebrand factor sets the limit for the factor 8 half-life. And that is the reason that we were not able to extend the half-life of factor 8 over the half-life of von Willebrand factor with the current concepts. And there's now a new concept, and maybe you all know it's BIF01, and the name is now ifanesoctocog alpha, where they try to overcome these challenges. And they use an FC fused factor 8, which is already on the market, and we have a lot of experience. And they couple this FC fused factor 8 to the von Willebrand factor D3 domain. And so they avoid that the infused factor 8 couples to the von Willebrand factor in the circulation. And second, there's an insertion to increase the half-life further. And with these measures, from a theoretical point of view, you can prolong half-life beyond the factor half-life of von Willebrand factor. And if you look now at the phase 1/2a results after a single infusion of 25 units per kilogram of BIF001 in comparison to 25 units of standard half-life recombinant factor 8, you can see that there is a relevant increase of half-life. So the half-life after this dose for BIF001 was 37.56 hours. And there was a much higher, a 7 times higher area under the curve, so much more exposition to factor 8. There was a higher in vitro recovery, and of course, much lower clearance of this product, which proves now that with these measures binding to the D3 domain of von Willebrand factor, you can prolong half-life of factor 8 over the half-life for von Willebrand factor. Which is important for the treatment is that with this approach, after a single injection of 25 units at day 5, we still have a factor 8 of 12%, and on day 7 of 5%. In the study, they used a second dose, a higher dose with 65 units per kilogram. And again, as you see, a very nice prolongation of half-life, in this case, in this patient group to 42 hours. Again, a 6 to 7-fold higher area under the curve. So exposition to factor 8 much better. And on day 5, still 38%. And on day 7, 17% factor 8. So that is a promising result. And there was another study, the repeat study, where the patients who were included get doses on day 1, day 8, day 15, and day 22. And there were 2 cohorts with 50 units per kilogram body weight and again 65 units per kilogram body weight. And in the study, again, safety and tolerability and PK in subjects with severe hemophilia A were assessed. The results of this repeat study confirmed the results of the phase 1/2A study. So the terminal half-life after 50 units per kilogram body weight was around 40 hours. There was no accumulation of the drug, and the mean factor VIII activity after 3 days was 46%, and after 7 days was 10%. So the decision was made for the phase 3 study, which is the extend study, to go for the 50 units per kilogram body weight once weekly as a prophylactic regimen. In this study, about 250 severe patients with hemophilia A are enrolled. There is a primary endpoint is, of course, a prophylactic efficacy in this prophylaxis treatment arm, and there are some secondary endpoints like consumption of factor concentrate, joint health, quality of life. There are some surgeries in the study, safety, tolerability, and PK. This phase 3 trial is ongoing. I can tell you at least that we have 4 patients in this trial and did already surgery in these patients. And I don't reveal too much to say that patients are quite happy with this once weekly regimen. And I'm really interested to see the results of these studies in the future. So I conclude. From my point of view, the replacement of the missing clotting factor is standard of care for patients with hemophilia A and B, because we still need in surgery, for instance, the possibility to measure factor levels, to adapt the treatment, and to protect our patients against bleeding. For prophylaxis, the approved extended half-life factor 9 products of our patients with hemophilia B already constant protection against bleeding with once weekly infusions, which is going, at least from my point of view, and in countries where these products are licensed, very well. With the approved extended half-life factor 8 products at the moment, we can reach higher factor 8 trough levels of 3 to 5% or even 10%. That is possible, but that require frequent intravenous injections of our patients. And you all know that some patients are not able to do this frequent intravenous injections. So there is a need, if we want to treat our patients with factor concentrates and with factor 8, that we have a need for next generation extended half-life factor 8 products. And there is a phase 3 study ongoing with the next generation extended half-life factor 8 products, which have the possibility to achieve trough levels around 10% with only once weekly injections. And I think that would be an improvement for our patients with hemophilia, beside all the things we have already. So thank you very much now for your attention, and I'm happy to take questions and to discuss with you.
Thank you, Mr. Kalamrat, for this fruitful speech. And this panel is open for questions. Yes, Jana.
İki konuşmacımıza da çok teşekkür ediyorum. Çok güzeldi konuşmaları. Ben aslında Türkiye deneyimimizden bahsetmek istiyorum. Türkiye'de uzun etkili faktörlerle ilgili çok sayıda klinik çalışma devam ediyor. Klinik çalışmalarda hastalarımız var. Onun dışında bu yıl ilk defa biz Elokta'yla gerçek yaşam verimizi sunduk. İnsani amaçlı erken erişim programıyla 8 hastamız bir yılı aşkın bir süre Elokta'yla tanıştı. FC domainiyle, FC eklenmesiyle uzatılan bir uzun etkili faktör. Bununla da gördük ki dün sözlü sunumlarda da sunduk. Burada hastalarımızın hem haftalık faktör tüketimi azaldı, hem yıllık kanama sayıları azaldı, hem de yaşam kalitelerinde belirgin bir artış elde ettik. Bu bizim için önemli bir veriydi. Ancak henüz ruhsat aşamasında bir ürün. Türkiye'de şu anda piyasada bulabileceğimiz bir uzun etkili faktör yok. Ama klinik deneyimlerimiz oldukça fazla. Emicizumab'la ilgili de henüz Türkiye'de Sağlık Bakanlığı ruhsatı var ama rutin SGK ödemesi yani mali ödeme açısından bir sorun var. Ama klinik çalışmalarda hasta deneyimlerimiz var ve oldukça iyi sonuçlarımız var.
Teşekkür ediyoruz Canan. Bizim hem ulusal verilerimizi sunduğun için aslında İSTH Kongresi'nde özellikle SOBİ firmasının 633 tane vakaya donasyon yaptığını yani bu verdiğini erken erişim sayesinde aslında bu çok önemli veriler toplanmaya başladıktan sonra dün de Mr. Makris de sundu. Yaklaşık 1/3'inde sanırım hastalarının İngiltere'de artık extended half'a geçmiş ama herhalde KLAMROTH'un da söylediği gibi birazcık daha uzun olursa hastaların tercihi daha güzel olacak herhalde. Hale senin bir sorun var galiba. Tamam. Başka soru? Bülent abi.
Ben de her iki konuşmacımıza teşekkür etmek istiyorum. Victor, Robert, welcome to our podium. Thank you very much. Şimdi tabii Victor'a şunu sormak istiyorum. Emicizumab tabii Hemophilia A'da çok önemli bir ortam oluşturdu. Hem Türkiye açısından da hem de dünya açısından bu büyük bir farklı bir yaklaşım getirdi ve onun arkasından da sistemi farklı yönlere kaydıracak diğer ürünler geliyor. Von Willebrand için ne dersin? Von Willebrand'da da tabii bir takım şeyler biliyoruz. Onunla ilgili ne dersin? Victor'a onu soracağım. Robert'a da ikinci bir sorumu da ileteyim. Ondan sonra mikrofonu bırakayım izin verirseniz. Şimdi tabii klasik standart rekombinan ürünlerde jenerasyonlar çok hızlı ilerledi. Birinci kuşak rekombinan ürünler 92'de çıktı. Ben ilk Meksiko City'deki kongredeyken Doktor Manucci ilk defa sunmuştu. Ondan Aledort'un karşılıklı atışmalarını izlemiştik tabii o yıllarda. Üstünden 30 sene geçti neredeyse. Bu 30 senelik süre içerisinde ikinci kuşak rekombinan ürünler geldi. Üçüncü kuşak rekombinan ürünler geldi. Şimdi tabii 2014'ten 15'ten bu yana da extended half-life ürünlerle karşı karşıyayız. Şimdi bunun ikinci jenerasyonu ilk defa geliyor. Ve 0001 çalışmasına benim de 2 vakam var. O çalışma içerisinde devam ediyorlar. Bunun arkasından bizi ne bekliyor Robert? Yani extended half-life ürünlerde 3. jenerasyon nasıl gelir? 4. jenerasyon nasıl gelir? Riskleriyle beraber, avantajları ve dezavantajlarıyla. Mesela bir ünite faktör 8 plazma faktör düzeyini %2 yükseltirken daha fazla yükselten ürünler görebilir miyiz? Ne dersiniz?
Well, if you like, Robert, I start by order.
Yes.
First, it's a real pleasure to see you there, Bulen and Cam. I apologize again for not be there. You were my fair intention, so thanks for the invitation. It's a real pleasure to see you there. You asked me about the role of emicizumab in von Willebrand disease. I think that there are some experience and some discussion about patients with inhibitor in von Willebrand factor in von Willebrand disease, and there are some good experience. But I agree with you that now we have the label indication of emicizumab mainly based on the clinical trials, of course. But now we are using emicizumab in other different conditions that are not on label, and we are having first some publication and some reports of with experience and also personal experience. I could talk about acquired hemophilia, von Willebrand disease with inhibitors, association with factor 8 in case of ITI. Try to prevent exposures or factor initiate. So I think that there are different protection against of anticoagulation. So I think there are a lot of different scenarios that probably in the future we will have with the arrival of emicizumab. I could say that because I am free here. It's not a sponsor meeting. So I think that, of course, we have to follow the label, but I think there are a lot of opportunities for emicizumab in this field. And one of them is, of course, there are some experience now published about the use in patients with von Willebrand disease.
Yeah, Bülent and Kaan, it's nice to see you. And I have to apologize too that I'm not in lovely Cyprus at this moment. But I think the story of factor VIII replacement therapy is a story of success. And if you look at hemophilia, replacing the missing clotting factor is always, from my point of view, the ideal thing to do because you have all the regulations of the coagulation systems. It works very well. The big disadvantage is you have to do it intravenously. And that is a great advantage of other drugs like emicizumab. So if you ask me what I perceive as a success in the future, I would still have said sub-Q factor VIII would be an ideal choice. But we all know one trial is stopped because of the higher rates of inhibitors after the sub-Q application. So if I look in the future, I think gene therapy will play a major role, maybe not AAV-based gene therapy, but other kinds of gene therapy. And I think we will more combine treatments, emicizumab as a basic treatment and additional factor for surgery or whatever. And that will be the future.
Thank you very much for the answers. So we have to end the session. Thank you very much for your contribution. It was very helpful for us. Hope to see you in Turkey next year.
Yeah, for sure. I want to see you and share with all of you, with Kaan, with Bülent, because I was excited because I think it was my first travel outside my country. But at the end, I am so sorry. My director saying no when I asked him. So we like to share again face-to-face meeting. Thank you.
Yeah, all the best for you and your Congress. And next time we will come to Turkey, Victor, together.
For sure. Yeah, for sure. Bye-bye.
Bye-bye.
Bye-bye. Burada bitiriyoruz. Katılanlara çok teşekkür ediyoruz. Hemen ara yok. İkinci 7. panel için oturum başkanlarını davet ediyoruz.